Hi, I'm Shelley Wood, the managing editor at TCTMD. This is On Record, a program looking at hot topics in interventional cardiology and beyond. And today I'm recording from the comfort of my own office, and my guests are Dr. Gennaro Sardella, Dr. Ghada Mikhail, and Dr. Javier Escaned. Thank you all for joining me here today. I wanted to talk today about STEMI. I think we've all been hearing about late heart attacks coming to hospitals, people avoiding hospitals, afraid to come in with symptoms. You are all in parts of the world, Italy, Spain, the UK, that have now coming somewhat through the pandemic. And I'd love to hear what's happening. Are people coming back to hospitals when they have heart attack symptoms? Are you seeing late presentations? That's the thing everyone's afraid of. Dr. Sardella, do you mind taking us off here? How are things in Rome?
Hi, Shelley. Thanks to having me today. Hi, Ghada. Hi, Javier. In Rome, we are closed. It was a lockdown for 40 days. Today's are the 40th day. And we face four scenarios, four main scenarios. The first one is the patients doesn't come to the hospital. Thus, as you know, and as you well described in your record live, it was a real decrease of the ST elevation myocardial infarction, about 30% in Italy. But the other three scenarios are the STEMI without COVID, without the infection, late STEMI without infection, a late STEMI with suspected infection, and a late STEMI with infection. Thus, we face three different scenarios beyond the patient that refused the hospitalization because maybe he's afraid of the infection, in particular in our hospital that is a COVID hospital. Because in Rome, they divided the hospital in COVID and not COVID. The COVID hospital, they are the hub hospital. All the other are the spoke hospital. When they arrive the COVID, they transfer the patient. They transfer the patients in another hospital. Our hospital is a COVID hospital. Thus, the patient maybe knows this problem, and maybe he refused to arrive in our hospital. But regarding the late STEMI, in all three cases, without COVID, with suspected COVID, and with COVID, in all three cases, we faced about 25 patients. In all three scenarios, it was a late STEMI because the patient without COVID, he waited at home to come in the hospital. And I had about 10 patients. They arrived after 1 week, 2 weeks, maximum 20 days. And in all these cases, because the pain, it doesn't disappear, they have a drop, they have ST elevation myocardial infarction, and they wait for the pain decrease a little bit, but if the pain remains, they come to the hospital, but very late. In all these cases, we observed a worsening of left ventricular function. In all these cases, they had maximum 30-35% of ejection fraction, arrhythmias, and in 2 cases, cardiogenic shock in the cath lab. The patient with suspected COVID, they arrived with like late STEMI because they arrived in the hospital. They have to wait for the test for the infection. They lose a lot of time. And they arrive in the cath lab 1 day later, 2 days later, with the same problems. And the patient with COVID, they stay in intensive care, they have a pain, and sometimes the physician that have to care the patient, it wait for 24 or 48 hours before to call the cardiologist to be sure that it's a STEMI, and even in this case, it's a late STEMI. In this case, we had 5 cases. 3 of those. This is very interesting. In all of these cases, we found a very big thrombus burden, heavy thrombus burden. They are very thrombotic coronary lesion. But in 2 cases, we did not make the PCI because the patient was in cardiogenic shock and they died after 10, 15 minutes after they call us. That it is a very great problem in all these 3 scenarios, with COVID, suspected COVID, and without COVID.
Okay, it sounds to me like some of the delay is the patient getting to hospital, and some of the delay is once they arrive at the hospital, there's the need for testing. Probably the patient is somewhat unstable with the symptoms of the disease that's delaying the treatment. So it's not just door to balloon time, it's also house to hospital, it's many delays. Dr. Escaned, are you seeing something similar?
Yes, thank you. Very similar. The pattern is the same. Basically, what we saw at the very beginning, like in China, like in Italy, they were ahead of us, is that we had a drop in cases suddenly, and we were wondering what is happening. I mean, we are not having, we're primary PCI center in Madrid, and we were not seeing these cases. And then following that, we also start seeing late arrivals, late presentations, patients who had some chest pain, but were refraining from coming to hospitals because they were afraid about the pandemic. And when they arrived, they have, massive myocardial infarctions. And the news started to spread regarding, like in our case, that we saw one case of a cardiac rupture, which luckily, was identified soon and was successfully treated with surgery. But we start to hear this news from other colleagues saying that the same was happening, and also in Italy. Today with Twitter, you keep a very active interchange of contacts. So this is one of the realities. Of course, I mean, now we have the government has issued announcements saying that you should not stay at home if you have chest pain, even with COVID, etc. But it's true that this effect certainly happened at the very beginning. And then commenting on other of the points that were raised by Rino, it's true that also we had this funny presentation of acute coronary syndromes in patients with COVID, or with high likelihood of COVID. Sometimes, a young lady with myocarditis-like syndrome, but also a lot of ST changes, etc. In other cases, you had the situation of patients who might have, were already in hospital with COVID bilateral pneumonia. Suddenly they go into ST elevation myocardial infarction, and then you find that there was a stent thrombosis, for example, of a stent that was placed there. Of course, we cannot establish firm links between the COVID infection and these things, but now we know that the COVID infection triggers coagulopathies and a number of situations that may raise, as Rino was saying, that you have this increase in thrombotic burden or even pulmonary embolism and these situations that we know associated to COVID coagulopathy.
Yeah. Dr. Mikhail, I think that the UK is just slightly behind,
Exactly.
Behind Italy and Spain. So what are things like where you are now?
So absolutely. I mean, we're reaching the peak behind, as you say, Spain and Italy, but we're seeing very similar things. So in the UK, we've seen a significant reduction in STEMIs and NSTEMIs, and just looking at our data from Imperial College here. So about a 50% reduction in STEMI presentation. Comparing this month with this time last year, about a 60 to 70% reduction in NSTEMI presentation. So massive reduction, quite a significant number of patients not presenting to hospital. And I think we kind of can speculate why that is. And we've talked about that. And we've heard from other parts of the world that patients are obviously anxious to come in. They don't want to burden the NHS. There's also the fact that people are probably less stressed at home. Blood pressures are low. They're not smoking as much, etc. But in terms of, and now there is sort of a big public awareness campaign raised primarily by the British Heart Foundation, also the government, to tell the general public that the NHS is open 24/7, that if you do have symptoms of chest pain, you think you're having a heart attack, come into hospital, don't delay, and that delay will cause harm. but still the numbers are low. We are beginning just to see the trickle, because we are behind Italy and Spain, the trickle of late complications coming in. So in the last few days, we've had a couple of patients that have had chest pain for 2 to 3 weeks at home, recurrent symptoms, and finally, because the symptoms got bad, they came in. LVs impaired, LV aneurysms, one of them in cardiogenic shock, and unfortunately both of them have done very badly. So, you know, and I think if we think we're going through a difficult time now, I think when the floodgates open, we're going to see a high burden of heart failure, arrhythmias, post-infarct angina. So I think I feel we're going to be overwhelmed with patients coming in with very difficult coronary disease and late presentations and all the complications that we haven't commonly seen and we used to see prior to the primary angioplasty service back in the in the 80s.
Yeah, I've heard somebody say that it's like traveling back in time and seeing some of these things that were more sort of just textbook cases back in the day. What about all the elective cases that aren't being done now? Do you have, and any of you can answer this, but the patients who are deemed elective for the time being, you know, stay home, your symptoms don't warrant it. Are you seeing a situation where people's symptoms are reaching the point where, yes, it's not an acute coronary syndrome, but they are rather desperately needing interventions? Or are you able to manage patients medically for the time being?
I have two interesting data. The first one is some data that we published yesterday. 15 centers in Italy, 14 centers in north of Italy, and 1 center in Rome, my center. In 14 centers of north of Italy, it was most affected from the outbreak. The decreases was about 35% of patients with STEMI. In Rome, just 15%. It was a decrease, but much less than north of Italy. That is very important if the region is most or less affected by the outbreak. In any case, the patient with COVID recorded for STEMI, that hospitalized for STEMI, has a mortality about 27.3% versus 7.9% in patients not COVID. Thus, I think that the problem is that when the patient is COVID in the hospital, it's already hospitalized. As Javier told before, you have a lot of comorbidities that is very difficult to treat only the STEMI. And sometimes the physician, he faced to the pulmonary problem, the embolism, but not to the heart. For this reason, maybe it's arrived lately. The patient without COVID has a decrease of mortality. It's a less mortality, but he arrives late.
Yeah.
Thus, there is this problem. There is a discrepancy. If you have COVID, you stay worse, but you arrive on time. But it's worse because you have other comorbidities. If you don't have COVID, you have less comorbidity, but you arrive late.
Yeah.
It's difficult to manage this situation.
Yeah, and Dr. Escaned mentioned the sort of coagulability issue that is really showing up in terms of the pulmonary embolism. And Dr. Mikhail, you were trying to jump in there with the elective procedures.
Yeah.
No elective.
So no, what we've done is we've basically categorized our patients into 4 categories, with category 1 being the critical patients that are at risk of dying. So these patients we have brought in because they're urgent patients and they have had procedures, not many, but they've had their procedures and we can justify that. But I think moving forward, if I may, what we are looking at now is sort of very early on, we had a COVID lab, which was for COVID positive patients and highly suspicious patients, segregated with its own ward. And the other labs were so-called clean labs, which I'm sure other centres have done as well. But what we're looking at now is reopening our clean labs and thinking of bringing back the elective cases into the clean labs and still segregating the COVID lab in a different section, if you like, to try and recuperate as a sort of recovery plan to try and bring elective patients back. So that's what we are looking at now. But we have done category 1 patients, actually in both PCI and TAVI patients. And in terms of TAVI, we've actually taken patients who, with critical aortic stenosis, symptomatic from the surgical waiting list, and have performed TAVI on them and managed to discharge them home the same day. So that's what we had to do. So we very carefully went through the whole waiting list and categorized patients into 4 categories, with 1 being the critical category.
Wow.
We are starting now a different way from the COVID and not COVID. We have a cath lab for COVID, a cath lab for not COVID.
Yeah.
But for the structural disease, it's very difficult to manage, because in our hospital they closed the cardiac surgery. That we cannot make TAVI. We make only balloon valvuloplasty as bridge, waiting the patient can. For the patient that he can wait for, or we leave the patient in we transfer the patient in other hospital.
Yeah, Dr. Escaned, some people have said to me that the burden of morbidity and mortality unrelated to COVID, but related to delaying some of these procedures, coronary as well as structural, will potentially even overwhelm the morbidity and mortality from COVID-19. Are you at all worried that by postponing procedures that these, these will level off in some way?
Of course, I mean, working the math for this type of comparison is very complex, but it goes without saying that, the efficiency of our system relies a lot on being able to deliver healthcare in time. So for sure that, if we are delaying particularly, and I insist also in the point that Ghada has raised, it is very important that the scheduled interventions that you perform at this point, when you are in the situation of a lockdown, for example, are those patients where you think that the intervention is going to make a change in the prognosis of the patient over the next month or over the next, in the very short term. And also, just to complement what Ghada has said, what our way of proceeding in this particular aspect is, if we have to do triple vessel disease because the patient is very symptomatic, etc., we try to focus in those stenosis that are accounting for most of the ischemia, and prefer to schedule the other stenosis for a second time. So scheduling or staging the procedure is a good way of increasing safety, because first, when we will come back and we will deal with the less relevant coronary stenosis, we will be in a situation where we can do much more comfortably all the use of intracoronary imaging, guidance. You will be reassured, but because you have a bed in the intensive care unit, for example, in case that you have a complication.
Yeah.
So we are exactly following the same type of approach. And yesterday we did our first TAVI. Again, because in our outpatient clinic now is virtually a tele outpatient. I mean, we are calling the patients. We identify a patient with aortic stenosis who was evolving unfavorably. So we managed to bring the patient to the hospital and performed our first TAVI over the last couple of weeks during the COVID status.
Yeah.
So I think that that's basically our strategy.
It feels like a light at the end of the tunnel to hear that these first TAVIs are being done. But the last question I have, and I know you're all busy and need to get back to your lives, but the other number that will be very hard to track are the cardiac arrests and deaths that are happening outside of the hospital. Is it possible in any way, I've heard of ambulance systems being overwhelmed, but are you able to track the patients who may be dying at home from cardiac arrest, unrelated to COVID or related to COVID? Is this a scary number, or is this being blown out of proportion by the media? Dr. Mikhail, have you heard of this being a particular phenomenon?
I'm sure it's a reality, but I think how you track it and how you find it out, I think, is going to be very difficult. Obviously, the government is monitoring deaths at home and outside of hospital, but that in itself is not an easy task. But whether it's related to a cardiac problem or not, I think is going to be very difficult to know and to work out. And I'm not really sure how we're going to be able to reach a conclusion as to whether the deaths were cardiac related or not.
It doesn't mean anything to the family that's lost a loved one, of course, but it does speak to the issue of the missing STEMIs and what's happening. Dr. Sardella, there was some numbers out of Italy looking at this.
It's very difficult, but we really don't know which is the really rate of death. This is the big problem. I think that there is only one way to make tests for infection in all the population. You will reach the real positive that die for death, for heart, for other comorbidities, or for infection. In this way, it's impossible. But it's impossible to have a real rate of death.
Well, I'm not sure budgets, healthcare budgets, are going to be able to afford autopsies on patients either.
In this way, difficult.
Yeah,
I think basically the problem has been highlighted already. Would be very difficult actually to know, but we know because the figures are there that if you look into historical figures, there has been certainly an increase in the number of sudden death. Now, what is unclear yet is in how many of these patients who had sudden death, how many of them were already COVID patients, because you know COVID patients may actually die suddenly, and we've seen that, and perhaps it's not actually a heart attack. Perhaps it's not myocardial infarction. So I'm sure that there will be a lot of retrospective analysis of all available data, and we will get insights in the future.
Yeah, well, this is a bit of a somber note to end on, but I am taking heart in the idea that you are treating some structural heart patients and you are making plans for elective procedures. So maybe we can check in some way in the months to come and find out what the lasting impact has been on your services, but also that perhaps things are turning around in some parts of the world. But thank you all very much for telling me a little bit about it today. I know our viewers will be very interested in this, so thank you.
Thank you, Shelley.
And thanks for all of you for joining us on Record.